Hi there, it's Rob Arnfield speaking to you again, and today we are going to discuss right ventricular assessment as part of our series on point of care echocardiography. In particular, we're going to address a couple topics which come up frequently among learners who seek to go a little bit deeper with their right ventricular assessments, and those techniques include TAPSE and RVSP, which we'll go into in a little bit of detail. So the right ventricle, unlike in many ways the left ventricle, has a laundry list of data points you can collect with which to inform your understanding of right ventricular function. These things include, of course, a global assessment of the size of the right ventricle, the IVC, and a number of the advanced topics that are on the table here. But what we will cover today is TAPSE, also known as tricuspid annular plane systolic excursion. You can see it earns its acronym honestly, given what a mouthful that is. So TAPSE it is. And we'll also talk about right ventricular systolic pressure determination, or RVSP. We will not cover more sophisticated techniques, including S prime determination, which is a tissue Doppler technique, PA or pulmonary artery acceleration times, nor will we look at pulse wave Doppler of the hepatic vein, which is another technique sometimes used for comprehensive right-sided assessment. Our choice to focus on TAPSE and RVSP relate to their frequent use in clinical medicine and their relative ease and applicability in making decisions at the bedside. So if you watched the comprehensive basic echocardiography module already, you'll be well familiar with the notion of an eyeball approach to assessing the right ventricle and an eyeball approach to assessing its systolic function in addition to its size. So of course we have two side-by-side images here. The image on the left is a normal right ventricular size and function, to say nothing of its abnormal left ventricle. Just looking at the right ventricle here, we can see the size is triangular. It is much smaller than the left ventricle, but we can also see the systolic function quite nicely. We can see the tricuspid annulus here, and if we follow that with our eyes, we can see that it contracts not in a concentric fashion, but in a longitudinal fashion towards its own apex. And that would be the classic mechanism by which the right ventricle systolic function can be easily appraised on echocardiography. Compare that with the adjacent image where we have a blown out large right ventricle, which is obviously overloaded by pressure and volume, but also we can see by turning our attention to the annulus, again, adjacent to the tricuspid valve, just with your eyeballs, you can see that there's very little movement of that structure in keeping with importantly depressed systolic function of the right ventricle. So that would be the eyeball method and a gross assessment. Now, we're comfortable with the eyeball method for assessing the left ventricle, and we kind of stop there with the left ventricle. Though we notionally make mention of the Simpson's biplane method or fractional areas of shortening, many of us at the point of care don't find that additional detail and labor of that assessment of getting a number for an ejection fraction, for instance, adds anything beyond our clinical eyeball assessment. And part of that is because those techniques are very labor intensive. Different is the right ventricle, where the objective mechanism of assessing systolic function is actually comparatively very easy to acquire, and that is the TAPSE, the tricuspid annular plane systolic excursion. And because it's easy to acquire, we often will capture it, even though I would argue it rarely adds additional details to my clinical decision making. I would say that very frequently people are interested and learners are interested at least to know how to do it, and because it is easy, we'll review it. So we've already talked about the eyeball method of the tricuspid plane, but now we can use a method to capture that motion, and of course motion in echo is captured using motion mode, abbreviated of course as M mode. And so capturing that motion involves placing a M mode line through the tissue of the lateral tricuspid annulus. And in so doing, we will be able to graph the movement in a fashion you'll see below these images now. So if we capture that movement, we'll get a graphical display of the tissue movement along the y-axis, with the x-axis being time. we'll show you a real live demo in a moment, but ultimately the peaks and valleys here represent the to and fro movements of that tricuspid valve annulus, and the absolute vertical height of that movement can be captured by simply measuring with your calipers. You don't even need to use the calculations package. It's really just a distance you're going to apply to the relative movement of that tissue plane. So the machine, of course, knows that the x-axis is time. So even when you draw a line that is on an angle, it will automatically take only the absolute vertical distance between these 2 points because it can't integrate time into the equation. So the easiest way to measure it, in my opinion, is just to measure along the slope of the tissue excursion that you see. And the machine, again, will automatically disregard the additional distance covered because you're kind of traveling the hypotenuse there of a triangle, and instead it will just take the absolute vertical distance. So that's my pointer there. But let's look at this in real time. So here we have a apical four-chamber view. Again, looks like a suspiciously enlarged right ventricle. We see the M mode line being deployed, and simultaneous with some probe manipulation, we get ourselves nice and centered there with the M mode line through the tricuspid valve annulus. And we disregard the near field content here and recognize that the tissue line of the valve here is the most hyperechoic margin of this tissue plane. This is all sort of valvular structure. And we can draw the line as we've done here, and we see that the TAPSE here comes out to being just over 10 millimeters, which is importantly depressed. And which raises the question of how do we interpret these values? Well, normal is generally somewhere between 22 to 24 or above, and frequently you'll see with normal subjects that it's above 24 millimeters. And then there's a sort of a threshold value, which is 16 millimeters or less is considered importantly diminished right ventricular systolic function. So in our last example, the function of the RV was importantly diminished, and the number that we achieve by that measurement doesn't disagree with what your subjective assessment would have been in looking at that right ventricle. However, by having a number, one can argue that you can trend changes in RV systolic function after initiating inotropy, potentially, and it can also inform some interdisciplinary discussion or allow some common language in sharing right ventricular systolic function when you relay the TAPSE number from physician to physician, potentially. So those are the upsides of doing it. Again, I would actually emphasize that I don't find it incrementally adds a lot of value to my assessment. However, it does give me a number to hang my hat on, and frankly is somewhat enjoyable to do and further deepens one's understanding of more comprehensive echocardiography and M-mode techniques to use it. Moving on, right ventricular systolic pressure is the next topic, RVSP, and this is a slightly more complicated technique. It will call on you to integrate a few different concepts, both physiologically and with respect to ultrasound physics and machine use. So let's go through it now. So the apical four-chamber view is the preferred view for this, though you could also use the parasternal short axis view at the level of the aortic valve, where you also have sometimes a pretty decent Doppler line on the tricuspid valve and right atrium. But let's use the apical four-chamber as it's the most intuitive, and we see the same clip of the pretty bad right ventricle we saw before. We see an enlarged right ventricle. We see very poor objective systolic function. We also know the TAPSE here is 10 millimeters from our last example. But now we're interested in understanding what is the pressure in this right side? What is the downstream pressure, effectively the PA systolic pressure in the absence of any pulmonic valve stenosis? We can determine that by using Doppler techniques. Determining RVSP is a two-step process. The first step is going to be to determine the pressure gradient between the right ventricle and the right atrium. This is going to call upon our Bernoulli principle, which is introduced in the Doppler section of these modules. And the second step you're going to do is going to be to obtain the right atrial pressure. This can be obtained directly if you have a central venous catheter, which are less and less common, I would argue. And so more commonly, you may choose to use the IVC size and respiratory variation patterns, which you may be aware of and we will review shortly. So using the information of the pressure gradient between the RV and the RA, which we're going to show you is determined by this equation 4V squared, the modified Bernoulli equation, plus the rate atrial pressure, we're going to be given a number called the RVSP. One thing you must have to even get started with this consideration is the presence of tricuspid regurgitation. The regurgitant jet and its speed is what allows us to determine the gradient between the right ventricle and the right atrium. So without any TR jet, you're kind of dead in the water. So you need to find the TR jet. And shockingly, some people with significant right-sided disease sometimes don't have a meaningful TR jet, partly because of pressure equalization across the RV and the RA in many cases. So it's not always available, but when it is, once you master this technique, it's actually pretty quick to be able to determine the RVSP. So the TR velocity jet, again, will govern the first step of this equation. And once that velocity is determined, you add it to the right atrial pressure to get the RVSP. Now, with regard to right atrial pressure, just a bit of review here, and that is that the right atrial pressure can be determined non-invasively. And the American Society of Echo and most cardiology labs endorse the use of the parameters shown here, which is effectively a ballpark range of right atrial pressure based around IVC size and respiratory variation. And I'm not going to read this table to you, but suffice to say that a large non-varying IVC is an elevated right atrial pressure somewhere between 10 and 20, and the average of 15 is typically used. And a very small IVC, or one with significant variation, corresponds to a low CVP, somewhere around 0 to 5, and everything else is kind of in the middle. So with reference to our RVSP determination, we've talked about right atrial pressure, but now we need to figure out how to resolve this part of the equation. That is the 4V squared, which again will tell us the pressure gradient. This term is the pressure gradient between the RV and the RA. So the tricuspid regurgitant jet is the window into that pressure gradient, as I told you. And the V in this equation stands for velocity. So really what we're talking about is we just need to understand the velocity of this jet. And if you watched the Doppler module, you'll recall that determining the velocity of flow requires spectral Doppler. You should also recall that there are two modes of spectral Doppler, pulse wave and continuous wave. So which Doppler modality should we use for this? Pulse wave would be a fair guess, of course, a 50% chance of being right. But many of you will recall that the pulse wave Doppler is excellent at resolving jets at precise locations, but is actually quite poor and unable to resolve very fast jets. And all regurgitant jets are generally quite fast and require instead continuous wave Doppler, which is built around resolving high-speed jets without the same spatial precision. It will track the fastest jet along this line, but as you can imagine, there's no other jet or speed that's competing at the velocities of this tricuspid regurgitant jet, so continuous wave Doppler will tell us exactly what we need to know with the absence of aliasing, because it can resolve jets of infinite speeds effectively. So that will allow us to solve the rest of our equation here. And so let's look at this in real time. So we have an apical 4-chamber view. We have color Doppler engaged to see if there is the presence of a TR jet, which we can readily identify here. And we fan the beam of the transducer to find a larger jet. We switch from pulse wave now to continuous wave, which is the diamond symbol. We're going to place that line immediately through the largest portion of the jet. And because the jet is moving away from us, I want to remind you that, of course, then the envelope of flow, of blood flow, will be on the underside of this baseline. So this represents the envelope, flow envelope, or spectral envelope of the tricuspid regurgent jet, and we can see that the velocities here are in meters per second or hundreds of centimeters per second, very fast velocities that would be unable to be resolved by pulse wave. And what's going to happen shortly is that we're going to ask the machine to resolve this velocity, the peak velocity, into pressure. And that's the 4V squared modified Bernoulli approach. So that we'll take this velocity, this peak velocity, and convert it to pressure. Again, the good news is the machine will do it for us simply by even pressing the caliper button. It will automatically acknowledge that if we're measuring in the Doppler mode, it will know exactly what we want. We're not interested in anything really other than measuring the flow characteristics, which will include converting the flow velocities into pressure. So you'll see that now where the calipers are going to be engaged, and in this case using the RVSP form of the calculations package, which is available on many of the machines. And we can see here that the peak velocity is nearly 3.5 meters per second, which it converts automatically into a peak gradient, which is the gradient between the right ventricle and the right atrium. And that simply is by plotting this number 3.5 into the 4V squared equation, pumps out the pressure. Now the machine, this is important, many machines will assume a CVP of 5 and will then give you an RVSP, in this case, just by adding 5. It doesn't know what your central venous pressure is. So what I would advise for you to do is to either manually modify the CVP in the machine or to actually just note in your own charts or your reports or wherever you put this detail, the actual RVSP. So it's just a common, a little pitfall or mental note you need to make there for getting the exact RVSP range that you think reflects the right atrial pressure. In this case, the IVC was seen to be 2.26 centimeters at its widest, with not a lot of variation with respiratory movement in this positive pressure ventilated patient. We refer back to our tables, of course, and see that this corresponds to a CVP of around 10 to 20, or an average of 15. So again, much higher than the 5 millimeters of mercury that were considered by the machine in the default setting. So we have 50.9 plus 15, and that's going to give us an RVSP of 66 in this case. And now that's quite elevated, with an RVSP over 35 technically being an area of concern. And so this would be in keeping with somebody who has significantly elevated pulmonary artery systolic pressures. And so again, the typical normal range is going to be around 15 to 30, and importantly elevated, depending on the clinical context, is greater than 35. Now, what you do with this information, whether you're acutely assessing somebody for an acute cause of pulmonary hypertension, like a pulmonary embolism, or you're managing somebody's pulmonary artery pressures in a more chronic fashion, is entirely up to you. And this is a wide open area, obviously, where RVSP is an important parameter in a number of different clinical scenarios. Of course, the gold standard for determining right heart pressures is right heart catheterization, and RVSP is not perfectly matched with that in all cases. And so there are some limitations to this technique, but it's an excellent screening tool at the bedside for elevated PA pressures, and has a lot of clinical application and use in most centers that I've worked or taught at. So some closing thoughts for you. I think RV assessment is easily done subjectively using the eyeball method, as I started with. However, frequently people want to go deeper with the right ventricle, partly because these techniques aren't super difficult. M-mode based TAPSE especially, RVSP starts to bring together a few more advanced concepts, as we've reviewed. As I mentioned, TAPSE's probable greatest asset is its ability to be trended quite easily between interventions. And RVSP is commonly used across a lot of different disciplines and specialties, and therefore using it may be part of a common vocabulary between you and the consultants you work with. And of course, we can trend the RVSP with therapy with afterload reduction of the right side, or pulmonary artery vasodilators, for instance. I want to thank you for your time. Hope you enjoy this screencast as well as the others in this echocardiography series. Thank you.